Okay. Good morning, everyone, and thank you for the opportunity to present to you all today. So I'm going to be talking about the Einstein aging study and some of the adjustments that we've made to our protocol in response to the COVID-19 pandemic. So I wanted to start by giving an overview of the Einstein aging study protocols as they were prior to the outbreak of the pandemic. So the study is conducted in the Bronx in New York, and it's a systematic probability sample of older adults aged 70 to 90 years old. And this current round of data collection has been ongoing since 2017. And this involved participants undergoing annual evaluations, which included 3 clinic visits plus a 14-day measurement burst. So each year their assessments were quite intensive. At the clinic visits, consent would be obtained, neuropsychological assessments would be conducted, plus questionnaires about demographics, medical history, socio-behavioral questions, as well as obtaining 2 blood samples from participants, one before and one after the measurement burst, and also conducting physiological measurements, gait assessment, and neurological exam. During the 14-day measurement burst, participants would carry a study-provided smartphone with the study app preloaded on it. For 2 weeks, they would complete up to 6 assessment sessions per day on the phone, which included a brief survey and some cognitive tasks. So they would do these assessments in the morning when they wake up, 4 times throughout the day when they were notified, and at bedtime. They would also wear an ActiWatch and a heart rate variability monitor throughout the 2 weeks. And on the final night, they would wear an oximeter to bed as well. So in March 2020, New York experienced one of the first significant COVID-19 outbreaks and stay-at-home orders in the United States. Over the 4 days, the Einstein Aging Study team shifted to working remotely and developed an IRB-approved protocol that involved fully remote assessment measures. This meant that staff were now conducting interviews via telephone rather than having clinic visits, and mailing out questionnaires to participants. Also mailing out the smartphones, the ActiWatches, and the oximeters, and pivoting to be able to train the participants in how to use these devices over the phone. So previously, participants would be trained when they came in for their second clinic visit, but obviously this wasn't possible anymore. We also updated our study app to be able to send the participants' data remotely to our server. So this meant that we reduced the risk of losing a participant's data if the package were to be lost in the mail and we weren't able to download the data from their smartphone. Some aspects of the study did have to be paused as these couldn't be done remotely, things like the physiological assessments and the blood draws. But there are plans to try and restart these again in the future using updated protocols to ensure the safety of participants. At the same time as transitioning to a fully remote protocol, an additional telephone survey was introduced to capture information about the participants' experiences during the pandemic. So far, we've completed 3 rounds of surveys with the cohort, with the initial interviews conducted from March to May, and then 2 follow-up interviews conducted since then. As much as possible, we used or adapted questions from existing measures, which I've listed on the left in the table there. So our survey included questions about COVID-19 symptoms, travel to outbreak areas, possible exposures to the virus, and diagnoses of COVID-19. We also asked about worry about contracting coronavirus, worry about access to food supply and medication access, and changes to behaviors or usual activities to avoid contracting COVID-19. So things like social distancing, hand washing, reducing times when they're going out to the grocery store, things like that. How much they were engaging with news sources and what types of media they were accessing, and feelings of anxiety related to media coverage, exposure to previous medical crises, changes in social interactions and feelings of loneliness, also positive and negative affect, and whether they had access to support if needed, particularly if they needed to self-isolate or quarantine. And we were able to provide referrals to support as well if people had an area of concern where they didn't have support. And just to show some preliminary results from our first phone survey, here I've briefly put some results looking at change in loneliness from pre to post-pandemic. So this data is from 226 participants who had completed the 3-item loneliness scale as part of their regular study assessment prior to the pandemic, and then who also completed the same scale as part of the telephone interview that we did after the outbreak in New York. So if we look at the mean levels of loneliness pre to post outbreak, we can see that there was no significant change. And really the scores here are quite low. So the level of loneliness is not very high. The scores on this scale can range from 3 to 9, with scores greater than 5 indicating the presence of loneliness. When we looked at the prevalence of loneliness using that CUT score of 5 to classify people as lonely or not, we see a trend for lower prevalence of loneliness after the outbreak. So from 19% pre-outbreak to 13% post-outbreak, with a p-value of 0.06, so approaching significance there. While this may seem unexpected given social distancing policies and stay-at-home orders, and especially that this data were collected in March and April in an area that was having these policies and orders actively implemented at that time, it's not wholly inconsistent with other findings in the literature that do indicate that there hasn't been a significant increase in loneliness during the pandemic for older adults. But I do want to make the note that this is in respect to overall trends, and it is important to consider individual differences to vulnerability to loneliness, and that's something that we're going to be looking into further with our data.
Kara, we are just at time, so do you want to wrap up, or are you done?
I am done. I just wanted to finally say thank you to my co-authors, to the larger Einstein Aging Study team, to the participants, and also just to acknowledge our funding sources. So thank you.